everybody okay um, for joining here today, and I'm going to be presenting on the exciting topic of economic evaluation and implementation research. Part of it just an overall sort of explanation of what cost effectiveness analysis is, and then we'll get into some of how to do it within a clinical trial. But this can be dense, material, and not everybody has, varying backgrounds in this. So please feel free to ask questions. So, all right. So learning objectives, cost effectiveness analysis, or CEA, what it is and why it's important. It is near and dear to me, so I want to help everybody understand and come to the conclusion that it is important. And how to incorporate CA into implementation science clinical trials, and then how to measure costs and effects. So what is, cost effectiveness? What does it mean? So an intervention is cost effective if it produces enough health to make it worth its cost. So it's all about good value or high value care compared to other health services. The goal of everything is health, to improve health and have good value for achieving health. So healthcare systems have to decide whether implementation interventions, are designed to reduce gaps in the quality of care. Are they going to adopt them? Are they going to implement them? And a lack of information on the cost is often cited as a barrier for this. So application of a cost-effectiveness analysis alongside studies can really help provide this information real time. So assess not only the effectiveness of your intervention, but assess the value of it as well. And that just added information to help adoption and dissemination. So background, as we all know, healthcare expenditures have really increased dramatically in the U.S. Going back to 1972, it was 7.4% of GDP. To 2021, 18.3% of GDP. That's like 13,000 per person. And resources are limited, and choices have to be made. So for non-healthcare decisions, it's easier to assess your cost quality trade-off and make the decision. Like, at the grocery store, are you going to pay more for those free-range, organic, pasture happy chicken eggs, or are you going to, go for the lower cost? So that's, you can make that decision. But for healthcare, it's really difficult to assess a cost quality trade-off. Are we getting the most health for our money? Or are we getting to our target of health as cheaply as possible? So the economic evaluation in healthcare is increasingly used to help inform these decisions. It's not, the first choice is like, is it effective intervention? Or is it worth doing because it improves something? But then we have to look at to demonstrate the most efficient use of available resources. Not cutting expenditures or blocking care, but really, are we trying to get the highest value of healthcare? So what is cost effectiveness analysis? So, down to its basics, it's delta cost over delta effects. The cost of your intervention and the effects of your intervention compared to standard of care or another intervention. So you have to estimate the cost of expenditures on your intervention and the value that's returned to patients and society, such as longer life, better quality of life, both. So you're going to have the information on the clinical effectiveness outcomes of your treatments for the trial. And this cost effectiveness analysis allows you to layer on information on the value of the treatments, with our end goal to maximize the effectiveness and health benefits of outcomes while minimizing the cost. So this is just a useful aid in healthcare decision-making processes. And for implementation interventions, you want to demonstrate that you're having a high value care. So there's a lot of different types of economic evaluations. The two main things to focus on is a point of view and the types of analysis. So the point of view, common ones are the society, that's the broadest. The healthcare sector, that's direct healthcare costs. The costs that payers and patients pay out of pocket for actual hard healthcare services. Patient perspective, that would be, for a patient, that's like time off, their time, their travel, their parking, their, childcare, their co-pays, and then provider. So that would be like the hospital. And for implementation studies, like the provider costs are actually a bigger focus than on a lot of trials, because you have to look at what it's going to cost the hospital to launch or adopt some of these interventions. So the recommended base case for cost effectiveness analysis from for the second panel is society and healthcare sector. Now, society is often really broad and gives sort of drowns out some of the specific questions that need to be looked at. So society is actually done less commonly than you would think. Healthcare sector, or the direct healthcare cost, is the most common presentation for the base case analysis. And then you also can add, depending on your stakeholders and what questions you're trying to answer, add on a patient and provider perspective as well in the analysis. But the point of view determines what costs are included. Because the costs from a patient are different from costs for the healthcare sector or provider. And then there's different types of analysis, and I'll go through these. Cost identification, cost effectiveness, the most common being cost utility. That's what's primarily done, and then cost benefit studies. And they differ, distinguished by what outcomes included and how they're quantified. So just running through some of these briefly. Perspective. Again, like we talked about, the perspective, the point of view is really key. And that is sort of like the launching of your analysis in terms of what type of analysis you want to do, what questions you want to answer, and that determines what cost you're going to collect during your study. So for example, again, I'm a urogynecologist, so cost effectiveness of a telephone versus in-person post-operative visits. We looked at several different perspectives. So healthcare sector perspective, that's medical treatment, the surgeries, complications, readmissions, ER visits, all that stuff. And then from the patient perspective, co-pays, deductibles, time, transportation, parking, childcare. And then societal, that's the broadest. It includes all the direct healthcare sector perspective, plus patient caregiver time, both paid and unpaid, transportation, lost productivity. So all three of those were presented in the paper to help, in terms of adoption. The healthcare sector and the patient perspectives were key. They were sort of stakeholders in whether they wanted to adopt this new intervention. So depending on the stakeholders and decision makers, there can be many perspectives to consider. So like a pragmatic solution, report multiple perspectives. So you have to have your base case, the recommended, healthcare sector perspective or the societal perspective. But then in addition, you're going to need the health system, clinic, patient, societal, and you can present all those within your results. Also different time horizons, 1 year, 5 year, you might need more than one result, one time period to answer different questions for different decision makers. And this allows various decision makers to use the results relevant for them. But it's really important to address as a priority to understand what questions you want to answer, who you need to have data for. So now briefly going over the different types of analysis. So cost identification analysis, like that little, it's cost A minus cost B. Other names include cost identification, cost minimization, cost analysis. So this looks only at the cost of an intervention, but not the benefits. So, don't do this. This is a very low quality type of cost study. It's appropriate only when two options of equal efficacy are compared. All you're doing is looking for the cheapest. So no comment on efficacy, it's just what's cheapest. So it can guide practice only when treatment has both lower cost and better or equal outcomes. So for trials, this is not what you want to do. So another one that's not commonly done is a cost-benefit analysis. Here, the cost and benefits are in the same units, usually dollars. So it's easy to interpret. It's either if it's a positive cost, a dollar amount, then it's cost effective. It's for value. If it's negative, then it's not value. The problem is identifying, valuing the benefit measurements, because you have to place the dollar value directly on a person's life, on a person's health. So that's rarely done. So I'm going to focus, really for the rest of the talk on cost effectiveness analysis. This is sort of the gold standard. This is, what's most commonly done and what's appropriate for a clinical trial. So here we estimate the cost in dollars and outcomes intervention in different units. So cost would be in dollars and effects are in other units. Usually the most common, the gold standard analysis is a cost utility analysis. So here the effects are expressed as quality adjusted life years. I'll be talking about it a little later, and it's not as intimidating as it sounds, but this delta cost over delta effects in quality adjusted life years gives you a result of dollars per quality gained. And this allows comparison across different diseases, populations, treatment. So, you can compare your outcome to, studies looking at diabetes or heart disease or, stuff just across the board, apples to apples comparison. And it allows us to say, look, our interventions are cost effective, are high value, fund us, adopt this. It's, it's higher value than the new cath lab. I'm joking. But the comparison really is what makes it the gold standard. Now, there are other possible outcome measures, and I actually generally encourage to have a second clinical condition-specific measure. You can use years of life gained, life saved, successful treatments, cases of illness avoided, other outcomes that are important for your condition. I like presenting a cost per improvement or in your primary clinical outcome. So if you're trying to reduce preterm births, so you would have dollars per, 1% reduction in preterm births or something. And that allows the clinicians to have, understand it a little bit more. But you really do need to present the gold standard cost utility analysis. So again, this is cost per quality, and it results from meaningful comparison with other interventions or just a predetermined standard. Again, and this really allows comparison of your new intervention to an existing practice. The UK has set guidelines, 20 to 30,000 pounds per quality gain to sort of, been their benchmark. The US, it's not used explicitly in decision making. There's no, specific, dollar value, but the range right now is $50,000 to $150,000 per quality gained is sort of the acceptable or considered high value care. So this is sort of the summary of what cost effectiveness analysis results are. And the primary outcome is this ICER, incremental cost effectiveness ratio. And that really is your delta cost divided by your delta effects. And this is the cost effectiveness plane. I'm just briefly going over this, but costs are on the y-axis, effects are on these are difference in cost, difference in effect are plotted on the x-axis. The origin here is your comparator. So that would be like standard of care. That would be the B up here with cost B, effect B. So this would be sort of your standard of care comparator. So in general, new interventions are up in this right upper quadrant, where your intervention costs more, but also does more. So this is where, cost-effective analysis can be informative. But the question is, does it cost a lot more and only a smidgy bit more effective? So is it really worth it? Versus it costs only a little bit more and it's a lot more effective, and so it's a no-brainer. The other place it can be informative is if your new intervention costs less and does less. It's sort of the question is it a lot cheaper and only a little less effective? Then it might be something to consider. But otherwise, you have the right lower quadrant where the new intervention costs less and does more. It's sort of a no-brainer, it dominates. Or the new intervention costs more and does less, well, then standard care dominates. But this is generally seen in the results section of cost effectiveness analysis to sort of summarize things. So now I'm going to switch over and talk about how to perform cost effectiveness analysis. There's two main ways to do it. There's model-based, and this you are just doing sort of a standalone where you're getting your effectiveness data from the literature, prior studies, experts. You get the cost data also from literature, databases, etc. And then you do a sensitivity, do your model, and it's decision tree or Markov model or Monte Carlo models, and you run it, but you do a lot of sensitivity analysis on your key assumptions since you're just pulling them from the literature. Or it can be collected as part of a clinical trial, performed as a secondary aim of the clinical trial. Here, you get both your cost and your effectiveness data from the same, clinical trial, and you really can combine the study results. If needed, you can, like if you have a one-year study, but you want to extrapolate it out, you can, extrapolate it out with a model based on your own data. Any questions right now?
It looks
right.
like there's
Yeah.
one question in the chat. It says, Hannah said, when you say effects of A and effects of B in the denominator, are both of these causal effects? So you need an RCT or good quasi-experimental measure of effects for both intervention A and intervention B. Is that the correct interpretation, or is it one RCT with 3 treatment arms?
No, it's your 2 treatment arms. If you're doing an RCT, you have, your 2 arms, that's A and B. So A is your, say, new intervention, and B would be standard of care or another intervention. So though you're comparing to your 2 arms in an RCT. Or if you're doing a model based, you're taking things from the literature, like, from the 2 different treatments you're trying to compare.
Thank you.
You're very welcome. So economic evaluations within clinical trials really can provide the best opportunity for developing information about your intervention's value. And it allows the data to be coming out right when the therapy intervention is first introduced. I feel like if you're implementing something, you can come up with both the effectiveness data and the cost effectiveness data at the same time. Can be used by policymakers or payers or providers, patients, etc. And really help with implementation and dissemination. So here are the steps in a trial-based cost effectiveness analysis. 1, quantify the cost of care. So it's really, really important to do this a priori. These are the perspectives we're going to do. This is the data we need. This is how we're going to collect it. Trying to do it after the end of the study is a mess. Number 2, quantify your outcomes. We're going to do quality adjusted life years as our primary outcome for the cost effectiveness piece. And our secondary outcome is going to be the primary clinical outcome of our study. Those are our two, and that's how we're going to present them. And this is how we're going to collect it. Then step 3 is assessing whether and how and by how much the average cost and average outcomes differ among the treatment groups. And that's just your regular, cost for group A, cost for group B, your differential and your p-value. Same thing with your different outcomes, whether it's QALYs or your clinical outcome, you just present that all, comparing the two groups. Step 4, and here's your primary outcome for your cost effectiveness study, compare the ICER. So compare the magnitude of difference in costs, so delta cost, and outcomes, delta outcomes, and evaluate the value for cost, and that's your ICER. And then step 5, really important, perform sensitivity analysis. You got to kick the tires and see, if any of the assumptions or, if you have different costs for, say, your home intervention, can it be a nurse or does a social worker or does it have to be, a midwife? If you kick the tires about who the labor cost on that, that could change the answer. So just looking at if you varied some of the key parts of the trial, cost, outcomes, does that change the answer? So ideals for this economic evaluation within a trial, and we rarely get ideals, but conducted in a naturalistic setting, you're comparing intervention with other commonly used intervention as would be used in usual care. Performed with adequate power to assess, the homogeneity of the results and the range of clinical settings and indication where this therapy will be used. Note, we don't do a separate power calculation for the cost effectiveness analysis if you're using your sample size based on who's in the trial. And you'd like an adequate length of follow-up to assess the full impact of the therapy, So if you're looking at, impact for reducing preterm delivery, like, do you need to carry on past delivery to get impact on NICU admissions or postpartum depression? We should follow out to a full year, maybe. You want to look at, assuming the study, you generally take the study time, but you'd like it to make sure it's long enough to really assess your intervention. Time frame that allows informing important decisions and adoption to dissemination of therapy. So getting it done and presenting the results to key stakeholders. Costs. Costs are the bane of the cost effectiveness analysis. So in general, standard economic assumptions, purchase price equal cost. Walk in a store, you see the price tag, you know what it costs. Healthcare, particularly in the US, doesn't work that way. Purchase price doesn't really equal cost, or generally you just don't know what the price is to observe. And this results from, high levels of insurance. People aren't having a fee for service where you can say, okay, this is what was paid. Regulation, there's free care, there's cross-subsidization. Consumers don't have, the information to really see what the costs are. Costs, what to include, again, depends on your perspective. So the formal healthcare sector is, direct healthcare costs. So what's paid by third-party payers, Medicaid, Medicare, private insurers, what are they actually paying? Not the bill, not the charges from the hospital, but the actual payment. Plus patient out-of-pocket costs for copays, deductibles, etc. And that would be your cost for the formal healthcare sector perspective. Then there's informal healthcare cost, patient time, caregivers, babysitters, transportation, parking, all that are included in the informal healthcare sector costs. And then you have the non-healthcare sector costs. So if you're doing a societal perspective, it picks up all three of these. And this includes larger societal impacts from productivity, consumptions, impact on social services, there are interventions, that can impact, decreasing legal or criminal justice system, education, housing, environment, that's really broad, looking at the impact of the intervention. So costs that you exclude on cost effectiveness analysis is anything exclusively related to research. So if there's a research only visit, not part of clinical care, your intervention, but it's for the research, tests related only to the research staff, all your CRCs, et cetera, research self-assessments as part of your intervention, those are excluded. Now, just to note, for implementation self-assessments, you would include these if it would be needed for the intervention to expand it out to another site. So if it's part of your intervention to say after the first month we do, these self-assessments and tweaking, et cetera, if that's part of your intervention, then you would include those costs. So measuring cost, again, it really depends on your perspective, societal, healthcare sector versus the patient versus the provider/hospital. So that's why you have to, a priori, really decide what are the perspectives we want to address for our question, for our intervention, to make sure we're collecting them properly. So it's really about the decision-making context. Who's our audience? Patients, physicians, hospitals, payers, insurance, or, are we trying to address policy? What's the question we're addressing? If we're trying to say, should insurance provide coverage? Then you want to look at the payer's perspective, the formal healthcare sector perspective. Is it worth patient time and taxpayer money? You can do the patient perspective or just the broader societal perspective. Should a hospital implement the program? Then you have to look, at the provider, because a lot of those costs might not be reimbursed. So in implementation science, it's a little different from just sort of regular, effectiveness RCTs, that there are a couple different areas of cost. You have your treatment, which is the evidence-based intervention that you're studying. But you also have the implementation cost. And this is the cost of changing the system, of developing an execution of your implementation strategy. So those two costs need to be evaluated and summed separately. And the approach to determining these costs are going to be different. The implementation costs are, and I'll get to the methods for calculating them can be different. And then also plus or minus downstream costs. These are changes subsequent to the implementation intervention, intentional or unintentional, that might need to be looked at as part of your intervention. For example, if you're talking about, impact of NICU admission or on the hospital, or impact of changing the location of a service from being, at the hospital, like the fetal monitoring, to at home. There are other things that need to be looked at as part of the cost effectiveness analysis if it will impact implementation and adoption of these strategies. Also, measuring costs, you want to identify how these costs change over time with the phase of deployment. Initial adoption versus sustained use might be different because, your volume, your capacity, the cost might change in terms of, more staff or more supplies, more space, etc. So here, getting into the nitty-gritty, how to measure costs. There's really two ways to do it. One is a detailed micro-costing approach, and the second one is resource costing. So with the detailed micro-costing approach, you have to collect the details of individual cost for labor, space, supplies. So this would be approach that would be needed in your implementation cost in terms of getting the program up and running. So for labor, did you hire a whole new nurse, or are you using your existing staff. So then you're going to have to calculate out, how much of your MA, your nurse, your doc, your, midwife, your front, back office staff, etc., are going to be used for this. You might need detailed time, motion studies, activity-based costing, etc., to really figure out how much of their time is being used for your intervention. Space, are you going to need additional office space or clinic space for your intervention? Supplies, etc., transportation, all that. And then you're going to have to cost out these detailed things. The resource costing method is commonly used for sort of the healthcare sector perspective. For this, you're measuring the utilization of healthcare resources. How many times they go to the ER? How many times are they readmitted? How many medication prescriptions they have? How many office visits? And then you extend them by average cost. So you don't want your local hospital cost. You want, for generalizability, you really want to look at national average costs. Medicare reimbursement, national average Medicare reimbursement rates are commonly used for that. Just for generalizability, you use the same cost to price out all your healthcare utilization resources. And again, this is for the healthcare sector perspective. You have you're trying to see what the payers are going to reimburse for this, or what the patients are going to have to pay, for this. The resource use costing method, again, you're tracking medical service uses. So when your CRFs are going forward, you just have to say, okay, your intervention procedure is going to, here's an average cost for that. Readmission, you track that. And ER visits, medication use, you don't get the bills for them, you don't get the receipts for them, you don't get the hospital billing statement for them. You just say, there was an ER visit, it was level 5, they got these tests, and then you just record the service use. How many times do they go to urgent care for a UTI? Then you multiply the number of units of each medical service by the average unit cost of that service in dollars. So we have X number of physician visits, and we're gonna, they average cost them assumption medical reimbursement level 3 or level 5 or whatever. So it allows a consistent capture of resource use when costs are incurred across multiple healthcare systems or payers. It really helps with generalizability. Micro costing, again, this would be often for the provider side. So if you're doing the perspective of the hospital having to implement a new strategy, a new service, a new, whatever the intervention is, your labor is going to be a big cost. So again, if you hired one person and that's one person's identified, great, you can get their full salary. But often you have to track activities and time, how much time the different people are spending on your intervention. We can do time and motion studies, activity-based costing, but you figure out their time. Then you get hourly wage rates plus fringe benefits, and just multiply that out. And you can, like the Bureau of Labor Statistics gives national average wage rates for a lot of different healthcare positions. So that helps with generalizability. You don't have to, getting your individual locations salary data might not be the possible or actually the most applicable. It's better to use national average prices whenever possible. Then supplies, equipment, just tracking what is being used for your intervention. Space, overhead, whether it's, sometimes you do the additional square footage and what your institution's cost is for that. It can be different for admin versus clinical space. And also information technology. You need, the IT people to tweak Epic to give you results, or do you need to do launch a whole new system to track your intervention? Now any questions like cost? You can spend like a lifetime getting into this cost stuff. It really has to be tailored to your intervention in terms of and your perspective in terms of what cost you want to collect. But the one thing I would just stress over and over again, make sure you have your plan a priori. Need to know exactly how you're tracking this, as you're going through your study. I've been approached many times at the back end where people want to do a cost effectiveness, analysis, and it's like I wasn't involved in the front end and the data wasn't collected. So that's really one of my big take-home messages. All right, now I'm going to switch over to measuring effect. I'm going to start with that quality adjusted life year. Everybody's like eyes usually glaze over with this part, but you really need it to have, if you're publishing results and all, they want the cost per quality that as your primary outcome in there. So cost effectiveness research again involves comparison of the incremental cost to your incremental health improvements. And the recommended measure for health is quality adjusted life year or QALY. So it is a common currency for measuring effect. So, everybody understands dollars, but for cost. So QALY is the common currency for measuring effect. And QALY is a way of summarizing all aspects of health in a single number. Time, length of life, ability to function, symptoms, pain, mental state, and it can really pull together morbidity, mortality, treatment effect. All of that are summarized in this single number, which is the reason why it can be comparable. So health states are valued on a 0 to 1 scale, with 1 being the anchor for perfect health and 0 is death. All health states in between are valued less than 1. So there are some theoretical negative health states, and that would be think of being perpetually teeth drilled without any anesthetic kind of thing. So, but in general, it's 0 to 1. These values are utility preference scores, but often called QALY weights. And what you do is you get measure time in a given health states. Like in your study, you measure baseline at different intervals. So each interval, is the time that they're spent in the state, and then you weigh it by the appropriate QALY weight to arrive, and then you sum it over your study. So that's to arrive at your QALY. But if you have a year and your QALY weight is 0.6, then your QALY is 0.6, quality adjusted life year would be 0.6. So it's a time-weighted health-related quality of life. But this allows comparison across a wide range of disease states, population, and treatment modalities. So then you can sort of compare, your results of our results is $50,000 per quality adjusted life year gain. And, you can compare it to the, cardiac study that was $100,000 per quality adjusted life year gain. So you can say our results have higher value. Look at us, adopt us, implement us, fund us. It allows us to be on common ground in comparison across different disease states again. And also populations, if you're going to implement your intervention in a low risk population versus a high risk population, you're going to have different results. So why do we need QALYs? Going to the U.S. cost effectiveness panels, there have been 2 of them, but the purpose of cost effectiveness analysis is to estimate the health gains and the cost of each intervention and compare them with other interventions. So comparability is essential if they're going to help decision makers evaluate trade-offs and choose among alternatives. So you need something that provides consistency across conditions and interventions. The reference case recommended a standard set of methods and assumptions. And the recommendation for the reference case, your base case, measure of health effect must be comparable across interventions and conditions and capable of capturing the impact of interventions with different effects. And quality of adjusted life years is a recommendation. So reference case should have QALYs for your effect. Now you can present other cases. You have your base case, and then you have your cost per, your clinical effectiveness measure. But you need to have that quality in there. So there's different quality. It's really actually pretty easy to do. That's why I'm stressing it a little bit here. The quality, to calculate these qualities, first you have to describe the health state for each time period in the evaluation. So you might have one measure for pregnancy, one measure for, immediately postpartum, one measure for, 6 months postpartum, 6 weeks postpartum, 6 months postpartum. And then you assign a value to each state using those quality weights. And then sum them up. It's basically you're calculating area under the curve with these weighted time intervals. The EQ5D, 5L is example of one of these systems. It's really easy. There's 5 questions with 5 levels each. So it's designed, it's a validated instrument questionnaire designed for cost effectiveness. It's a utility preference score instrument. And it's very most commonly used quality system in high income countries. There's availability in the US weights for this instrument, and it's been widely validated. I'm actually finishing validating it in a very diverse urban pregnant postpartum cohort right now. So it can be used in it's widely used and can be used in your studies. So it's just a questionnaire with 5 questions, so it's easy to add. So in addition to that, I'm really, as you can see, pushing the qualities to have that there. But then for clinicians reading your study, decision makers, they might want to have other condition-specific measures. Well, urinary incontinence, since I'm a urogynecologist, one of my studies had the cost per quality, and then the secondary one was incremental cost to decrease 1 daily incontinence episode. So it's cost per reduction in incontinence episode was our secondary measure. Cancer, if you're doing a new screening intervention, you might have incremental cost per cancer detected. Medical management of non-viable early pregnancy, our secondary measure with incremental cost per percent completion of miscarriage treatment without a uterine aspiration. All of these are things that clinicians can grab onto and might be more meaningful way of anchoring the results. This can be the primary, but often I recommend doing a secondary cost effectiveness outcome. Because what if utility score is not sensitive to change or effect? It usually is, but that can be an issue. And also just it's more meaningful to clinicians to have some clinical effectiveness outcome. Discounting, if the study is greater than a year, you need to account for the differential timing of cost and benefits. And so you state what year your cost or value is at, and then you discount both cost and outcomes. US standard is 3%. If your study is less than a year, you don't have to worry about that. So finally, sensitivity analysis is very important. So you really want to demonstrate the independence of the result on a particular assumption, cost or outcome. And really identify critical variables or values of variables that might tip your answer. For example, if you substitute job classifications, wage rates, if you have, again, do you need a nurse practitioner or just a nurse to do your intervention? Do you need, how much time, the wage rate, what assumptions would be your tipping point, your break-even point? Program volume, like, is it different if you're at capacity versus you only have like a few people in the program? At what volume does your program tip to being cost effective? Example of a recent study, the cost of mifepristone, the rate of miscarriage completion without needing an MBA. Ectopic pregnancy rate in a population, methotrexate success rate, the results could be different if you're in a population with a very low ectopic pregnancy rate for pregnancy of unknown non-location treatment. So you just want to identify uncertainties requiring further research or uncertainties that might impact a decision maker to adopt some of your interventions. All right, so this is sort of, I've got a couple examples of studies that I can walk through, but I want to stop here because, there might be questions in terms of particularly measuring costs and stuff, and I'm happy to answer some questions. Oh, come on, isn't that like utterly mind-boring?
It doesn't look like we have any questions in the
All
chat
right.
at this point. Also, feel free, for those who are here, you can also ask questions specific to your own projects that you're working on. It doesn't have to be just general about the content, but if you have one specifically with your study or project, feel free to pop that in there as well. But we have about 10 minutes left if you wanted to run through an example.
So I'm gonna, this is examples of studies. So this is again, I'm your gynecologist, I'm sorry. So this is comparing for urge incontinence, sacral neuromodulation versus Botox. So again, sacral neuromodulation, because you all are so familiar with all these incontinence treatments, is a pacemaker placed under the skin of the tush there with a lead going to S3, and so it's done in the operating room. And the battery, actually now they can last more like 10 years, but by the time of the study, they were 4 to 6 year battery life. And then Botox, Botox temporarily paralyzes all those annoying muscles, wrinkle muscles, spasmy bladder muscles. So this is in the office once or twice a year, usually, where you go in and inject Botox into the bladder. We had an effectiveness trial that said at 2 years, they were equivalent in terms of clinical effectiveness. So the question for the cost effectiveness is sacral neuromodulation, SNS, cost effective versus the Botox injection for the treatment of urgency incontinence. And 2 years was our trial, but because of the battery life going out to 4 to 6 years, we did a model-based extrapolation to 5 years. But our primary outcome, again, is this ICER, the delta cost of the InterStim versus the Botox divided by the effectiveness, which is QALYs, of the InterStim versus Botox. And then we're going to explore, that's our 2 year with our within trial comparison. And then we're exploring, over longer if we extend it out through 5 years, where the battery, that should give a benefit to the InterStim because it lasts longer. So we wanted to do that, and that's model based. So cost, we did healthcare sector perspective because this is really looking at direct medical cost and trying to, at that point, we're trying to get Botox covered more. InterStim was already covered. And we used a resource costing method. So we had all the healthcare utilization data from the actual clinical trial. And we just then used Medicare national reimbursement rates or published prices for our to value our healthcare utilization. For effects, again, our primary effectiveness outcome with the QALYs, and we measured it with the instrument throughout the study. And then we also had a condition-specific measure, and here we picked reduction in daily urinary urge incontinence episodes, because that was one of our clinical outcomes. So here, we had our delta cost at 2 years, delta effects, that's the cost differential. And look, this is sort of the punchline. Look how much it costs for the InterStim because it's done in the OR versus Botox is done in the office. So a huge price differential, and that was significant. The effectiveness measure, average QALYs, was not different. They both, again, just we knew clinically they work the same. So really no difference in effect, but a huge difference in cost. So the ICER, it was totally dominated by Botox. It works the same and it's a lot cheaper. And 5 years, okay, we said all right, let's give the InterStim a benefit of the doubt It's really not more cost, just a few little tweakings and a couple, sometimes they have them take them out because they're not working. But basically, not a huge increase in cost in 5 years because they already got the OR expense. And Botox, they got to keep coming in, getting, once or twice a year more Botox. So those costs went up. And we extrapolated the qualities again, saying, okay, we'll just say they work about the same. But still, there was a huge cost benefit for the Botox. It even at 5 years, the cost differential was huge, and no difference in effect. So it's still dominated by Botox. And the same thing with our clinical effectiveness thing. The quality effect measure similar to the clinical outcome. They're measuring. They both measure the underlying utility of improving incontinence. And so cost was significant, again, effect not significant, so dominated by the cheaper one, the Botox. And here's that, lovely, I love this, cost effectiveness plane, but our price points, so everything is above the horizon. So everything, it costs more. InterStim costs more, both at the 2-year and the 5-year, the orange and the blue. Our point estimates were all in this upper left quadrant where InterStim costs more, was less effective, so forget it, Botox dominated. And then these are our, the confidence intervals are where the points scatter. And here is a cost-effective acceptability curve showing okay, so willingness to pay, like we talked about in the US, is about 50 to 150,000 quality gain willingness to pay, and we're way out here. It's the InterStim is not even close, so it's not cost effective. So then we did sensitivity analysis. Okay, what if we reduce the InterStim device cost? How much does it have to go down to break even? Well, at 2 years, it had to come down 69%, and at 5 years, 60%. That's a lot of cost coming down. I don't know if the device manufacturers would be willing to drop their costs by that much, or really the hospital for their surgical costs. And how about Botox? What if they needed a lot more injections? So if Botox, if they needed 6 per year, then it broke even. Well, in the study, it was 1 to 2 per year. So that's a bit of a stretch. Okay, and so what if the rechargeable technology just is, we had amazing revolution and it works, forever. So the rechargeable technology, it has to last at least 25 years for it to break even under the current, based on the trial data. So they have come out with rechargeable, but they're saying, 15 years is the max. So it still holds that kicking the tires pretty vigorously, that Botox is, that InterStim is not cost effective compared to Botox. So conclusion, effective measures, they both work. They're both great. There was no difference between groups. They are the 2 highest effective interventions we got. Cost, however, were significantly higher for the InterStim, both at 2 and 5 years. So the analysis shows that favored Botox over InterStim at 2 and 5 years. So conclusion, InterStim in its current form is not good value compared to the Botox. But, significant reduction in cost or change in technology could change the answer. So just thoughts to consider on that one, though. The insurance coverage is generally better for the higher cost InterStim than Botox. So are we really getting the target of health as cheaply as possible? We're getting both health for our money. Can we substitute a more cost-effective intervention, with for less cost-effective ones? And then just also lowering costs can make well, not any, but can make some treatments cost-effective. So where are we now? 3 minutes. All right. I won't go into the pre-fair trial, but questions?
I have a question.
Yeah.
Kate Rindle, you had said early on, sort of a poor decision is to just compare the cost of the intervention. That's often done, I think, in implementation when we're thinking about implementation costs. So we're not really looking at the effectiveness. Sometimes we do, but sometimes it's just to understand what the implementation costs are to then be able to report to other health systems if they were thinking about implementing. I definitely see that effectiveness adding into that would be much stronger. But do you think we should do that at all? Meaning, do you think it sort of is undermining some of the tenets of this work if we continue to only assess implementation costs?
Well, the implementation costs are one component of your cost effectiveness analysis. So it's sort of, there we go, you got to do, okay, I can't even find where you are. So you have to do your implementation costs, you do. But, and if it's comparing to standard of care, it's like nothing versus your implementation cost. So you absolutely have to do it. And that's something that would be a portion of a cost effectiveness, study. And you can do portions of things. You don't have to do the whole, but if you are planning an intervention, you need the implementation costs but you also need, what you're implementing.
Right.
That's your treatment.
Right.
So the treatment really is where the cost effectiveness comes in. You have your treatment versus standard of care. You should be improving effectiveness. Otherwise, why are you doing doing your intervention?
Right.
So
right.
At the end of your trial, you're going to have our intervention improved blank. So that's your effectiveness. And during your intervention, just you can administer the EQ5D and get your quality too. I mean, you don't have there are plenty of studies that just do cost per clinical outcome, so I don't want to, say you can't do that. I'm just trying to stress the gold standard. But yeah, you absolutely, so to answer your question, you need your implementation cost. You can publish that separately, absolutely. But if you're doing a trial, you need to have the implementation cost plus your intervention and the cost for that, and then your effectiveness, and then your outcome.
Yeah.
And the implementation costs are part of your intervention. So if another hospital's gonna, or health system or whatever is going to implement it, they need to know their upfront implementation cost and then the cost of running the treatment and the effect of that. So they're different pieces, but it's good to put them all together in one big analysis. But tracking and publishing your implementation cost, yes, that needs to continue. Absolutely.
Yeah, no, and I think we can do a better job of the intervention and the effectiveness to include it and really have a full picture. So thank you.
Oh, you're welcome.
Wonderful. I think that brings us at time. I'm going to stop the recording.